Hello, good morning.
Good morning, Gaetano. Hi.
Hi, Marian.
Thank you for coming. Thank you for your help. Next speaker is Professor Gaetano Isola from University of Catania. His topic is multidisciplinary treatment of periodontitis patient in the new era of clinic and research. Please, Gaetan.
Thank you, Marian, for this kind introduction, and thank you for both of you, Professor Samanarayak and you, for this kind invite. For me, it's a great pleasure to be here in this important congress with some international speakers. I am Professor Gaetano Isola, and I'll try to share my screen. Just a moment. I will try. I'm trying to. Okay. I hope that this is fine. It is a great pleasure to be here. I'm assistant professor, I'm associate professor of periodontology at the University of Catania, Italy. And today I will present some...
Excuse me.
Yeah.
Sorry for interrupting. We cannot see your presentation. We can only see the Google Meet. You share the Google Meet.
Just a moment.
Conference.
I will try to again.
You can present now and share the entire screen. Is the third option. And then you can open your PowerPoint presentation. Doing this way.
Okay. The full screen.
Yes, the entire screen.
The entire screen. Now, how is you can see?
1 second. Yes, you can see it.
Okay. This is the full screen of the presentation.
Yes, it is in full screen.
Okay.
It's working.
No, it's okay. Thank you. I am associate professor of periodontology at the University of Catania, Italy. I work actively with several colleagues of my institution in periodontology, and thank you again for inviting me to this great congress that is held every year online. I will talk this morning about how is important to treat patients with periodontitis and how is important a multidisciplinary treatment of these patients with periodontitis that is not only focused on the periodontium, but usually the patient with periodontitis has several systemic link, and we will talk about how is important to control this kind of link between oral health and systemic health. Today we will talk about the detrimental effects of periodontitis, maybe linked with the initial stage of disease like gingivitis and periodontitis. Then we will talk about important to the management of the oral microbiome, these kind of patients, and then we will remove this, and then we will talk about the systemic interaction between periodontitis and systemic disease, and how we can do a proper minimally invasive treatment in order to reducing also the systemic impact of the treatment of periodontitis. As we know, periodontitis is a multifactorial inflammatory disease. It is a really complex disease of bacterial origin, and how is important that we should treat this kind of disease in the early stage of disease. This was a patient that referred to our unit of periodontology before the COVID appearance, and as we can see, she come with a reduced and an important alveolar bone loss and tooth mobility on several teeth on this mouth. And if you can see, this is a patient of 23 years old with no systemic disease, no smoking, and the main problem of that patient was the late diagnosis of periodontal disease, and this should be the main problem. And in such case, what is the cases? Because as we can see, there is no huge amount of periodontal plaque, no amount of other problems. And in such case, as we know that the early diagnosis of diseases is really fundamental for the then treatment. In order to treat this kind of patients, we have to push back our mind and to think about the importance of the microbial ecology of the oral cavity. As we know, the oral cavity to represent an open system, ecological system, in which we will find some microorganisms organized in oral biofilm. The oral biofilm is a complex organization of oral bacteria that are protected by several things, and now we will talk about it. And these kind of bacteria are embedded inside to the oral environment. That should be important also to know, especially in the late part of the treatment, because the only oral biofilm cannot allow the destruction of periodontal tissue, but the periodontal tissue destruction is mainly due by the host immune response that in some patients that are predisposed to disease starts the really important thing about the periodontal destruction. The other important things that about the patients with periodontitis that usually the patient has no clear diagnosis, and they don't know how they have the destruction of their own gums. As we can see in this case, we can see maybe a patient with healthy gums, but with a simple exam due with a colorant of a plaque, we can know that the periodontal disease is important in the different things like maybe tooth malposition or presence of calculus or something else, in which we can see that is not in the full mouth, but when we refer the periodontal disease is a disease on the single periodontal sides. As we can see, there is a huge amount of dental plaque in specific sides of the mouth of the patient. And when we treat a patient with periodontitis, it is important to know that the really treatment should be done on the single sides, on the single periodontal sides. Usually, it's important to know that the first stage of periodontitis is already done by a dysbiotic bacteria, and that is followed usually by an uncontrolled inflammatory response that is mainly due to a low chronic infection on periodontal tissues, in which we have the colonization of the biofilm. On the colonization of the keystone biofilm pathogens is followed by the release of several inflammatory mediators that starts the initial part of the connective tissue destruction, and then followed by the alveolar bone remodeling in a bad way. In such case, the most important things should be done when we treat a patient with periodontitis is to focus on the characteristics of neutrophils, macrophage, dendritic cells, and other keystone inflammatory mediators that starts to fight with a dysbiotic microbial community. And in such case, in the first stage of disease, it is important to analyze the activation of the acquired immune system in the predisposed bacteria. In the first stage of disease, we will see that there is a movement from the healthy condition to the gingivitis condition, in which there is the first release of the several acute inflammatory process and several inflammatory biomarkers that starts the invasion inside to the bacteria and to the periodontal pockets, and with some pro-resolution mediators downregulate the recruitment of some immune cells and uptake of several neutrophils that start inflammatory lesion. When we refer with a patient with periodontitis, this is the main part to treat the disease. Usually when the patients come to me, with advanced destruction of periodontal tissue, and we have to think that the most important thing is to treat a periodontitis when it starts directly with the gingivitis, because there should be no periodontitis without any gingivitis states of the disease. Then the most important thing, unfortunately for our patient, is the second stage of disease that I underline that is important. This kind of patients, the predisposed patient to disease, there is a movement from gingivitis to periodontitis. In such a phase, already there is no strict consensus how should be the first mediators of the destruction of periodontal tissues, and in such case there is a really immune response that involves both innate immunity players that starts the subclinical destruction of periodontal pockets, because in such case the patient don't have specific symptoms of disease, but usually is underlined in a specific way. Then there is the third stage of disease, in which we have the periodontitis, and there is the release of several pro-revolution mediators with the main activity of the lymphocytes T and B, and there is a physiological reaction aimed at protecting the organism against the specific periodontal bacteria. And such case is important that should be controlled, maybe the release of the lymphocytes P and T. Then we know that usually the inflammation from periodontal disease move from the periodontal tissue directly to the systemic one. And in such case, it's important that patients with periodontitis should be controlled not only from the oral inflammation, but also on systemic one, in which there is the release of several inflammatory mediators, some of them that are shared with certain systemic disease, with cardiovascular disease, diabetes, and something else, in which there is the release of C-reactive protein, fibrinogen, serum amyloid, and should be this kind of disease affect several other apparatus like the gut microbiome with the dysbiosis, the liver, the heart, and also the preterm in certain patients. In this case, as dentists, we have to put our attention maybe to find some biomarker of disease, and one of them, it was shown by the study of Pan and Ayuden colleagues, that found that in the blood, if we have a CRP values above 3 milligrams per liter, from 3 to 10, we have to put our attention to about the risk that the patient has not only on their mouth, but also on the systemic apparatus, maybe the cardiovascular disease and the other ones. In such case, a mechanism of bone loss should be also correlated with a specific balance. It was a study that we performed several years ago on the positive correlation between the Renkolo OPG ratio and periodontitis patient, in which we have to know that also the bone activity in our periodontitis patient should be not perfect. However, the main issues about the periodontitis, that from a systemic point of view, should be an unbalanced oxidative stress pathway status, and this should be the main pathway that should be underline the role of periodontitis and cardiovascular disease, or maybe periodontitis diabetes, in which we have found in several studies that we have performed on blood and on saliva, that there is a specific different oxidative stress pathway of patient with periodontitis that's really common, maybe with some certain activity of endothelial destruction. In such case, the periodontal inflammation and systemic risk should be done by the release of several inflammatory cytokines and the genetic susceptibility determinants. In such case, the research on periodontal disease is too preliminary. We don't have specific guidelines of specific studies that found some genetic polymorphism of patients with periodontitis, but the most important thing is to control the bacterial burden, that if we resolve and reduce the huge amount of bacterial burden on periodontal tissue, as for sure we can control the release of the inflammatory response. For this, we have to underline the important thing of the gingival biofilm, that is a complex organization of microorganisms that with a specific complex biological interaction and the presence of polysaccharide extracellular matrix control the whole organization of the biofilm, especially for specific antibiotics or anti-inflammatory components. And if we have to know that we should treat periodontal disease, we have to disaggregate this biofilm organized in a specific thing. In such case, I had the honor to work with Professors Sigmund Sokransky and Professor Ray Williams, that study for over 40 years the huge amount of periodontal tissue organized in a specific biofilm that is totally different from the supragingival biofilm to the subgingival one. They found a specific pyramids, the Sokransky pyramids, in which they analyzed the specific bacteria, the red complex, in which we found P. gingivalis, Bacteroides faucitus, and Treponema denticola, and also the orange bacteria that are more virulent and they have the ability to disrupt the periodontal tissue. And we have to know that in the supragingival plaque, unfortunately, we have some certain periodontal pathogens that they are really low activity on periodontal destruction, instead of the subgingival biofilm, in which we find the complex of orange red bacteria that mainly determines the periodontal tissue destruction. As we know, there is totally difference between the supragingival biofilm and the subgingival biofilm. This picture should be translated into the fact that if we would like to treat a patient with periodontal disease, the main thing is to treat the subgingival biofilm. We have to focus our attention as a clinician to find the subgingival biofilm, because the presence of specific pathogenic bacteria, this is the model developed by Roy Page and Kenneth Corman in the 1997. There is the release of the antigens and lipopolysaccharide bacteria that determines the host-immune inflammatory response, the connective tissue destruction, and the expression of the disease and progression, in which there is a specific negative circle, and that determines the clinical aspect of periodontal disease. Moreover, we have to know that patients with periodontal disease, these are the study of Riccardo Teres, that was also an alum from Professor Sigmund Sokransky, determines that the patient with periodontitis has a specific range of bacteria from the quality and the quantity point of view. And we have to know that patient with periodontitis is a specific cluster of bacteria that is totally different from a healthy patient, and we have to focus our clinical attention. Also because the periodontal activity is really determined to periodontal dysbiosis and detrimental effects of not only in the mouth but also in the gut. When we treat a patient with periodontal disease, we have to know also that we may improve not only the oral mouth but also the gut, and in certain patient, we have to know that it's important to treat this patient. This was underlined also by Ian Chappell in 2025, in which there was found that there is a movement from the clinical health to periodontitis to a symbiosis, to a frank dysbiosis. We have found also that our biofilm should be organized in a specific cluster of bacteria, and in which there is the movement from the eubiosis to the dysbiosis to periodontitis. There is like a quorum sensing of periodontal bacteria that determine the activity destruction of periodontal tissue. Also, the mainly systemic effects has been underlined. In such case, a study of Montserrat in 2016 found that periodontitis is linked to over 57 systemic disease. In such case, we have to know that many of clinical trials in the last decades study the impact of periodontitis in systemic disease and found several disease linked with periodontitis. And as we have to know that there is a specific increased trend of systemic condition and periodontitis, this increased during the last years. In the over the 30% of periodontal literature now study the effect of periodontitis and systemic disease. The mainly activity and the mainly disease related with periodontitis has been found like the cardiovascular disease. Maybe we have found atherosclerosis, coronary disease, hypertension, myocardial infection, and other diseases that could be really determined the impact of the quality of life in our patient. Because there is a specific impaired endothelial dysfunction, the patient with periodontitis has a impaired arterial stiffness, and also the thickness of the carotid intima media and the calcification score that is really impaired compared to healthy patients of people without any inflammation. And the inflammation should be determined as a low increase of cardiovascular disease through the mechanism. One is the direct mechanism, in which we have the ulcerated periodontal pockets that enter to the periodontal bacteria, and then the systemic circulation and the subclinical risk of periodontal disease. And then through an indirect and indirect mechanism, there is the possibility to determine the increased level of inflammatory mediators, and then determine the systemic inflammation. In such case, the role of inflammation is important. This we have to know that from the second part of my speaking, control the inflammation is really important to improve the clinical aspect of the disease. We found that patient with periodontitis has specific and certain pathways linked with both serum and saliva, with a common sharing things about the inflammation. Another pathway that should be important should be the impact of periodontitis also with the microRNAs, that now has really important mediators of several subclinical risk of inflammatory disease. And we have found that patients with periodontitis and periodontitis plus cardiovascular disease has the same common risk and the same common mediators. The message should be treat periodontitis, should be treat also the cardiovascular disease. Also is the same with diabetes. That is important because the reduction of inflammatory mediators of patients with periodontitis and diabetes should also control the host tissue bacteria and related degradation product that should be worsening the status of diabetes patient. Also, we have found several years ago that the main important things of periodontitis and diabetes is to treat the pre-diabetes status. We found that people with periodontitis should have the same systemic status of patient with diabetes. And also, like the treatment of gingivitis, also the periodontitis should be reduced the pre-diabetes status. Is the same with the neurodegeneration. We found the study of Iagoler and colleagues that also patients with periodontitis has the high risk of severity and the possibility of develop some neurodegenerative disease like Alzheimer's disease on the other ones, and also treat patients, elderly patients with periodontitis should be reduced the risk of the worsening of Alzheimer's disease. We have found also that, like we have talked about, the link between oral and gut microbiota in periodontitis patients, and as we know that we have to focus how they are the objective of periodontal treatment. What be our goals in a periodontal patient, what we can do for our patient. One should be disrupt the biofilm, because we have talked that it is a complex organization of bacteria. Then we have to reduce the subgingival pathogenic microflora, and with the related thing of the control of the inflammatory and host response. But the main problem should be the prevention of the subgingival regrowth of gingival tissue, because we know that it is quite impossible to eliminate the gingival bacteria, but we have to control the appearance of the bacteria that are present in subgingival biofilm. For this, important thing is that should be released the guidelines by the European Federation of Periodontology, in which is important the periodontal treatment, and we have to reduce the proportion of microflora from a compatible one to a really reduced number sites of periodontal activities. Moreover, we have found with the colleagues of Giovanni Salvi, Klaus Lang, and Tony Sculian that is important the role of non-surgical periodontal treatment in this kind of patient, and we have a critical point of probing depth of over 3 millimeters should be determined as an high risk to the further develop of periodontal disease, maybe in the treatment of surgery approach. The first thing is that when we found the endpoints of successful periodontal treatment is a correct non-surgical periodontal treatment approach that should be done on the lateral aspect of the ultrasound instrumentation, and we have to spend a lot of time. I prefer usually to do the quadrant scaling root planning, may be translated now in the quadrant subgingival instrumentation, and we have to focus the attention on specific instrument. We have also find some adjunctive agents. Not only are important the ultrasonic instruments, usually are fundamental the manual and hand instrumentation done by the curettes, the crazy curettes, but the important things is also to diagnostic properly the periodontal disease, because the presence of probing depth of over 5 millimeters is a study by Werogd on the 1978 should be found that patients with probing depth of over 5 millimeters should be reduces the efficacy of non-surgical periodontal treatment. This should be translated to the fact that patients with important pockets should be then treated by the surgery. It is important to note that the classic periodontal treatment, mainly by hand and in ultrasonic instruments, should be reduced only the 70 and the 40% of the bleeding on probing. This should be, and not only, but also the calculus, they should be reduced from the 5 to the 60%. And for this reason, we have developed several operative strategies in which now we will focus our attention on the minimal invasive approach that should be usually performed by minimally surgical, minimally non-surgical, but especially surgical approach. It is important to know that when we'll talk about the minimally invasiveness of both non-surgical and surgical periodontal treatment should be found by specific control of the edema, pain, inflammation. There is a reduced risk of also flap recession procedures and something else. We have found in a study several years ago that a minimally invasive approach is important also for the non-surgical and surgical periodontal treatment, and this kind of approach should really improve our outcomes, our healing outcomes in periodontitis patient. This should be performed by different things. Once it was developed by Professor Leonardo Trombelli with the single flap approach, in which we'll find the treatment of patient with infrabony defects on the vestibular aspect, and the other one, it was the modified minimally invasive surgical approach developed by Tonetti and Cortellini, that found how is important to prevent the presence of papilla and the environment on the periodontal infrabony components into a successful treatment of patients with periodontitis, maybe with the strong use of the matrix protein derivatives and also specific bone. These are the results that we have performed on patients with infrabony components. We have published several years ago with the successful results of these patients with a 5 years follow-up. Now we have found that a minimal invasive approach in specific patients with periodontitis, especially with infrabony components, should be improved the quality of patient. Also because the most important thing is the last part of the periodontal endpoints, that is the periodontal supportive treatment, and it is important that the not only the proper treatment by the dentist, but the control of the oral hygiene, to avoid smoking, to have a specific balanced diet should be also improve the outcomes that performed in the periodontal chairs. Mainly because the patient with periodontitis should be also treated when the case is really balanced and with a reduced amount of dental plaque, also with implant approach that should be performed in a safe way with the low risk of develop of periimplantitis. These are the results of our study that with 5 years follow-up, we found that also patients with a minimally invasive approach should also develop in implant dentistry. Mainly because we have found that professional treatment and a minimal invasive approach should reduce the release of certain cardiovascular disease outcomes. And for this, important is to treat with a minimal invasive approach these patients. We have to conclude that in our experience, the main improvement to treat periodontal patient is to reduce the periodontal pathogenic bacteria, and especially with the K factor in the early stage of periodontitis. The most important things is to properly treat patient with a non-surgical periodontal approach that should be mainly performed with a quadrant-wise approach. But the most important thing is that in the non-surgical periodontal treatment should be performed by skilled people with the use of hand and ultrasonic instruments, and also to dedicate time for a proper treatment. We have to know that maybe a treatment of a single quadrant should be over 40 minutes because the quality of our treatment is really linked to the time that we have to dedicate to our patient. We have found that other adjunctive adjuvants like antibiotics, systemic and local one, we avoid the use of lasers. Maybe the use of erythritol or something should be only part of the non-surgical periodontal treatment that should be mainly performed by the use of only hand and ultrasonic instruments. But we do know that in such case, the step 3 of periodontal treatment now would become fundamental. It should be performed in sites that are that they has the presence of deep pockets of over 6 millimeters with probing depth of or in a pockets of 4 millimeters but with bleeding on probing. In such case, usually the patients move to the surgical approach, in which is important to know that we have to correct the bone defect with a specific treatment. And from the data that we have in literature, that we don't have a single specific therapy in our patient, but should be personalized our approach to the single patient. Our objective are surely to reduce the number of periodontal pathogens. We have to try to modify the habitat of our periodontal environment, and we have to think about how to modify and control the chronic inflammation, because when we try to lower the pathogens not only in this site, but we have to focus to not treat non-diseased periodontal sites, because treat a non-diseased periodontal sites by specific and ultrasonic instruments should be also start some periodontal lesion. But the most important thing in our patient is to start and to specific prepare supportive periodontal program, in which we have to specific to personalize our approach in patient periodontal disease. The most important thing, however, is a specific periodontal approach, and for the future, maybe we know that we should treat patient with prebiotics and probiotics. At this specific stage, we don't have specific and certain guidelines on the treatment of prebiotic and probiotic in our patient. Also, maybe some good news should become by pro-resolving mediators, in which are linked maybe with a specific diet approach, and should be find certain good anti-inflammatory effects, especially when we compare it to NSAIDs or other systemic drugs that has a really important systemic impact. And then in the future, just for sure, the epigenetic therapy will determine a change in gene expression, and maybe we could follow and we could find some most important things about the epigenetic therapy, but the research in such case is too preliminary to be draft specific conclusion. Just for sure is important that maybe also the stem cells in the future could be help ourselves. Surely we have to move for the find of very biomarkers of periodontitis, and the new challenge should be start on studies on large number of population through a non-invasive approach, and in such case the study of salivary mediators, but specific gingival clavicular fluid mediators should help us in a proper treatment of periodontitis. We have to know that the treatment of periodontitis should be also change our patient, and we know that also periodontal treatment should improve the quality of life in several patients, as we can see. I would like to thank you, Professor Constantinescu and Professor Samanariake, for this kind of opportunity. I invite you to visit our region, Catania, that is beautiful, especially now that we are in November. This is our university. This is located in the center of Catania. And thank you again for this great opportunity. And thank you for all of you that were here to answer me.
Thank you, Isola, for your contribution and for your very interesting presentation. Thank you so much.
It's a pleasure.